So this part of the lecture is designed to give you an overview of the kinds of treatment services that have been developed over the past 50 years or so in a variety of different countries. And we'll be talking about alcohol treatment services, drug treatment services, harm reduction programs, and brief intervention and brief treatment. These types of services are delivered in a variety of different settings, and in some cases they're combined. So you might have a facility or a program that deals with both alcohol and drug treatment as well as harm reduction. We'll be talking about the effectiveness of these different types of services, as well as the amount of research support they have in the literature, and whether the research has been conducted in a variety of different countries. So you can see here that for many of the services that we're going to be talking about, ranging from brief intervention to pharmaceutical therapies, that there is evidence for effectiveness. 3+ means it has the highest amount of effectiveness evidence, and 3+ under research support means that there's been a lot of research conducted, and 3+ in the cross-national column means that there's been a lot of testing in different countries. So brief intervention with at-risk drinkers is something that has now been found to be effective, has lots of research support, and good cross-national testing. Similarly with medical and social detoxification and talk therapies. Residential treatment was the preferred way of dealing with people who had a severe alcohol problem. And this usually meant taking them to a hospital, and in many countries, a psychiatric facilities, and later to a facility that specialized in alcohol treatment. And over the years, because these types of residential facilities required long-term care, they proved to be quite expensive. And they were evaluated in a number of different countries, which found that for most people who had an alcohol use disorder, it didn't make too much difference whether they were treated in an outpatient facility or a residential facility. There was some indication that residential treatment, however, can be indicated, especially for patients who are highly resistant to treatment, who have few financial resources, and come from environments that are not conducive to recovery. So getting them out of an environment where there's lots of temptations to drink is a good reason to put them into a residential facility. And especially if they have co-occurring medical or psychiatric conditions that require additional attention. There are a number of adjuncts to the traditional treatments that have been developed for outpatient counseling as well as inpatient residential detox and often rehabilitation. Naltrexone is an opioid antagonist, a drug that operates on the opioid system in the brain. And the opioid system, surprisingly, has been found to be influential in the development of alcohol use disorder and in the reinforcement that people get from drinking. So if they're given an opioid blocker drug like naltrexone, it interferes with the reward that they get from drinking, and it could reduce their desire for drinking and reduce the rate of relapse. So a pharmacological adjunct to treatment is often incorporated into residential and outpatient programs. Similarly, Alcoholics Anonymous and other mutual help organizations provide support in the community. And they have been proven to be very effective in helping with this continuum of services that are available to people with alcohol and drug problems. Is alcohol treatment effective? Well, as we mentioned in the last lecture, yes. There's been a good deal of research over the years that suggests that people who get treatment do better than people who do not get treatment. And they have better outcomes in part because of the contact they have with a clinical facility, a program, a therapist, or a drug that they're taking. The type of help they receive doesn't make too much of a difference. And that is quite surprising. Since we have a variety of different types of treatment, all of them seem to be more or less effective, some a little bit more than others. But the important thing here is that it suggests that the sooner we get people into treatment, the better. The intensity and the duration of treatment above a minimal level do not seem to make too much of a difference. And inpatient treatment, as I mentioned, versus outpatient treatment for most patients doesn't seem to make a difference. There's little evidence that one type of psychotherapy or pharmacological approach is superior to others. And we'll be hearing more about this as we go through different studies that have been done on these topics. Drug treatment is a parallel area to alcohol treatment and uses many of the same techniques, but also specialized techniques that have been developed for particular types of substances, like opioids or marijuana or stimulants and cocaine. So drug treatment and harm minimization depends on the substances, the settings, the modalities, and the programs. Drug treatments have been designed specifically for opioids, some treatments for stimulants, some treatments for cannabis, and other treatments for polysubstance use. Like alcohol, drug treatments can be delivered in outpatient settings, residential settings, but it's also been expanded into treating people while in prison, and now, like alcohol, we're moving into the primary healthcare area. Different modalities have been developed, including individual counseling, group therapy, therapeutic communities, contingency management. I refer you to the glossary in your readings to get definitions of this rich variety of different types of treatment. Harm minimization programs is another area within drug treatment that specializes in reducing the harm rather than just operating at the level of reducing substance use itself. Needle exchange programs are a good example. They reduce high-risk injection practices, high risk meaning risk of infection, particularly from HIV, but they have the added benefit of making contact with people in the community so that when they come in to exchange their needles, they also might contact a nurse or a counselor and begin to develop a relationship. So needle exchange not only minimize harm, they might also help to reduce substance use. Naloxone is an antagonist drug that blocks the effects of opioids and can reverse an overdose. And this, when it's distributed in the community, can have often life-saving effects to minimize the harm that comes from high doses of opioids. Safe injection sites have been tested in a number of countries, including Switzerland and Canada. And these are places where people can inject drugs under medical supervision without police interfering. While this is controversial, what the research suggests is that they can reduce overdose fatalities, prevent HIV infection, and, like needle exchange programs, begin to engage drug users in the process of recovery by beginning to receive counseling and referral to treatment. So what do we know about harm minimization versus treatment? What we now know is that there's no sharp ways to distinguish them. There is some harm minimization that's implicit in treatment. When people come into treatment, they're taught about safe injection practices while they receive abstinence-oriented therapy. But within a harm minimization program, people can also receive encouragement to go into treatment. What we do know, it's not only drug users who benefit, but everybody benefits, families and the communities by these programs. And there is little evidence to date that by introducing needle exchange programs or take-home naloxone to prevent overdose, that it encourages drug use. On the contrary, it begins to engage people in a therapeutic process. So, what is the overall effectiveness of drug treatment services? Well, the chapters of the book Drug Policy and the Public Good describe for each of these different types of treatment what the evidence is. I won't go into detail, but what we now know is that medication-assisted therapy, especially therapy that includes methadone and buprenorphine, tend to be quite effective in reducing not only the harm from substance use, overdose deaths, HIV infection, but also they help people to recover from substance use and get on with their lives. Needle exchange programs, peer self-help, naloxone distribution, all of these different types of treatment and harm minimization have reasonably good evidence of effectiveness, so that they are part of a spectrum of services that can be used to drive down the rates of HIV infection and drug dependence. Here's an example of a treatment trial that used randomized techniques to compare different types of treatment for marijuana dependence. And we're going to be talking about the Marijuana Treatment Project in subsequent lectures in this course. But this is to give you an example of people who get randomized to either a waitlist control group where daily cannabis users were asked to wait 3 months before they could begin their treatment. And what you see here is that they were using about 90% of the days prior to randomization. And after 4 months, they were still using at that rate. If people were randomized to 2 sessions of brief intervention, lo and behold, they went from about 90% of the days that they smoked marijuana after 4 months of 2 sessions of treatment, they were down to about 60%. That is a statistically significant improvement in the frequency of their marijuana use. If they were randomized to a group that promised 9 treatment sessions with a therapist, even at 4 months before they received all the treatment, they were doing better, which suggests that perhaps the anticipation of treatment, the knowledge that they had a support network, a therapist to work with them, was responsible. So this is a good example of how treatment research can demonstrate whether treatment works or not. Other types of research are more in terms of evaluating health services, like prison-based therapeutic community programs. And here what we found in a number of different research studies is that if people don't get any therapeutic community program while they're in prison and they have a history of drug dependence, that their recidivism rate, once they get out of prison, is quite high, 50%. If they're exposed to even a few sessions of a therapeutic community, their recidivism rate goes down to 45%. If they complete therapeutic community, it goes down to 40%. And if they complete therapeutic community programs and they also have aftercare in the community, their recidivism can go down to 8%. This is an example not of randomized trials, but of observational studies done in prison settings of treatment and its effect. One other thing, I mentioned that there wasn't too much of a difference in different types of treatment, which in general is true. But one treatment that seems to stand out is contingency management. And this is providing systematic use of rewards. It could be monetary, it could be a ticket for a raffle, it could be just social reinforcement for behaviors that the therapist or the program manager wants to encourage, like when they come back to pick up their methadone, turning in a urine sample that suggests that they haven't been smoking marijuana, they haven't been using other drugs. When good behavior is reinforced, it increases the type of outcome significantly. So what have we learned from drug treatment about its effectiveness? Well, there's strong evidence that opioid substitution therapy is effective, also contingency management, peer self-help, and all the others that have been listed in these charts and in your readings. There's growing evidence for the effectiveness of harm reduction programs for injection drug use. So the good news is that we do have effective treatments. And particularly with harm minimization, we can begin to drive down the rates of HIV infection and overdose by making these services available in the community. In general, the treatments that we've developed for opiates and opioids being synthetic drugs, are quite effective if we can give people a choice. And the variety of different types of treatment might be used to match the needs of individual types of patients.